Hello, good afternoon to everyone connected from across the country to join the National Association of Latino Healthcare Executives Tri-State Chapter's Pride Month event. My name is Melissa Molina Trinidad. I am the president of NALHE Tri-State Chapter, and it gives me great pleasure to welcome you to our event. We have the honor of hosting with two experts in LGBTQ health. Thank you for your time and insight. If you're new to the NALHE family, I'd like to take a few minutes to share with you highlights of our professional association. NALHE is an organization with a little over 16 years in the making. Our mission is to promote health equity for Latino communities by increasing Latino and Latina representation within healthcare systems and by supporting policy, legislation, and regulation that seeks to improve health and healthcare for diverse communities. Our vision sets the runway for our future to be the professional association of choice that transforms the Latino and Latina experience in the national healthcare leadership space. We promote and practice authentic leadership, being genuine, self-aware, and transparent. We want you to inspire loyalty and trust. We champion diversity, equity, and inclusion initiatives. We advance various perspectives and ideas, and we strive and work diligently to position you to have a role, a voice, and a seat at the leadership table. The NALHE footprint spans from the US via multiple chapters. Our growing members and partner network represents students, early careerists, mid to senior level executives, physicians, nurses, and other industry professionals that seek to connect and share best practices. We welcome you to connect with NALHE and the NALHE chapters listed on our website at www.nalhe.org. And we also invite you to think about starting a NALHE chapter in your region if one does not exist today. At NALHE, we are really proud and thankful to have multiple health industry partners and sponsors for their generous contribution. In these partnerships, it's the key to ensure that together we work cross-market and competitive boundaries and have core values and a unified priority to create inclusive opportunities. We welcome a connection with your organization to consider sponsoring future NALHE events. I would like to thank our chapter board for giving emphasis to this critical topic. Thank you for your servant leadership, multiple volunteer hours, and for designing and launching today's activity. With that, enjoy the presentation. My best wishes to you all, our attendees, partners, and members of the NALHE family. Thanks again for joining us. I'd like to now invite you to the virtual stage, our NALHE Tri-State Chapter Treasurer, Gabriel Paz.
Thank you, Melissa, and good evening, everyone. Happy Pride. My name is Gabriel Paz, and I'm the treasurer for NALHE's Tri-State Chapter. I also work for NYU Langone Health here in New York City, where I'm the Assistant Director of Business Development and Operations within the Department of Clinical Affairs. It gives me great pleasure to welcome you to our webinar, Health Equity at the Intersections, Latinx and LGBTQ Health. We have the honor of hosting Christian Mendez-Baez, Prevention Services Manager at Edge, New Jersey, and Dr. Patrick Cahill, Medical Director of HIV Primary Care at Hartford Healthcare. I'll properly introduce Christian and Patrick once we begin the panel discussion, but thank you so much to both in advance for your time and your insight. In the next hour, we're going to present an overview of current progress and disparities in LGBT health, particularly from Latinx communities, and we will have a moderated discussion with Christian and Patrick here, where I will ask them questions pertaining to the topic of LGBT health and their perspectives on it, as well as their career paths as members of the LGBT community. Towards the end of the discussion, we will open the forum for questions from the audience. So why are we hosting this event? So today, in commemoration of Pride Month, we're hosting this webinar to have a conversation about LGBT health, which has made advances over the years, but still has long ways to go from an equity and access standpoint, particularly for those in communities of color. As you might all be aware, the LGBT community faces greater health challenges than heterosexual individuals. This is due to a combination of different factors, such as differences in sexual behavior and the disproportionate rate at which diseases like HIV/AIDS impact the community, and social and structural inequities, such as stigma and discrimination, that come as a result. We're aware that a conversation around LGBT health and the added layer of intersectionality make this topic a complex and nuanced one that can be covered in its entirety within an hour. So think of this as a webinar as an introduction, this webinar as an introduction to the topic with perspectives from experts in the field. So the past few decades haven't gone by without some progress achieved. Among some highlights that we find, and bear with me, this is a selected list of highlights. It's not the entirety of it, but for example, the World Health Organization removed homosexuality from the International Classification of Diseases in 1990. That was just 30 years ago, believe it or not. Conversion therapies aimed at changing sexual orientation have been banned in 20 states, although there's still no state law or policy that does the same in half of the country. 22 states have legislation prohibiting health insurance discrimination based on sexual orientation and/or gender identity, and 24 states have prohibited transgender exclusion in health insurance coverage, although 27 states have no law providing similar insurance protections. Another highlight is that advances in antiretroviral therapy such as PrEP and PEP have significantly decelerated the spread of HIV/AIDS. We also have 22 states that have policy that explicitly covers gender reassignment procedures, and the Department of Health recently expanded the scope of Provision 5057 of the Affordable Care Act to prohibit discrimination against someone on the basis of their sexual orientation or gender identity. So although there have been advances to narrow the equity gap for LGBT individuals in healthcare, there is still much more to be done, particularly because we still see discrimination and disparities. And just some statistics that we selected to show you this. 29% of transgendered Americans have been refused care because of their gender identity. 15% of LGBT individuals have avoided medical treatment due to discrimination. Another 30% of LGBT individuals face difficulties just last year accessing necessary medical care. Roughly 10% of LGBT individuals said a healthcare provider used harsh or abusive language when treating them. 1 in 3 transgender individuals had to teach their doctor about trans identity in order to receive appropriate care. And then we see that nearly in half the country, there are no laws providing insurance protections for transgender individuals and no laws banning conversion therapy. So the implications of this are pretty severe. Discrimination and even the potential for discrimination can deter LGBT people from seeking care in the first place, and structural barriers limit their ability to do so. Factors like low rates of health insurance coverage, high rates of stress due to systematic harassment and discrimination, and a lack of cultural competency in the healthcare system leave LGBT people at a higher risk for cancer, mental illnesses, and other diseases, and make them more propense to smoke, drink alcohol, use drugs, and engage in other risky behavior. And when looking into the statistics for Latinx and other individuals of color within the LGBT community, the disparities are even more staggering. This is due to the fact that 42% of LGBT adults identify as people of color, including 21% who identify as Latinx. Transgender women, Black, and Latinx men have the highest rate for HIV infection. 1 in 10 Latinx transgender people are HIV positive. 23% of Latinx transgender people reported being refused medical care due to bias. 64% of LGBT Latinx adults have health insurance coverage compared to 77% of all LGBT adults and 82% of the heterosexual adult population. And 26% of LGBT Latinx individuals don't have a regular source for basic health care. The reasons for these disparities vary and encompass different cultural and behavioral barriers, some of which include limited English proficiency. So Spanish speakers account for nearly 2/3 of all limited English proficient individuals in the US. While the National Standards for Culturally and Linguistically Appropriate Services in Healthcare has issued recommendations for culturally competent care, interpreter services, and organizational support, it is unclear how adherent health systems are to these regulations. So this lack of open communication between patients and health providers may prevent information sharing, such as the disclosure of gender identity or sexual orientation, and deliberation about treatment options. Family and friends of Latinx patients who have limited English proficiency also often act as translators in clinical encounters, and this may impede patients from discussing sexual orientation and gender identity topics with their provider if they had not previously disclosed to their family and friends first. Another barrier is the documentation status. Roughly 70% of undocumented LGBT adults are Latinx today. As a result, many undocumented Latinx LGBT patients experience even more barriers that prevent them from accessing medical care and building trusting relationships with providers. Some of these barriers or additional barriers include fear of deportation, not wanting to disclose immigration status to providers when seeking services, the inability to take days off from work, and lack of access to immigrant-friendly services, which can reduce opportunities to engage in high-quality communication. Furthermore, religious beliefs. Latinx LGBT patients who have strong religious ties may experience cognitive dissonance between faith and identity, which may affect disclosure of sexual orientation and gender identity to providers whom they perceive to be religious. Erosion in this patient-provider trust due to assumption about providers' religious beliefs and internalized religious conflict may hinder communication among Latinx LGBT patients. Next, family stigma and social support. Among LGBT Latinx individuals, strong family connections and friend networks are associated with a positive sense of self. Latinx LGBT patients may be forced to make medical decisions on their own without the family support that they may prefer to have, which decreases their self-reliance and increases their reliance on providers in the decision-making process. Latinx LGBT patients may also opt out of healthcare altogether because of a lack of familial support. Then there's the traditional expectations of masculinity. It's no secret that machismo permeates across Latin culture. Identifying as gay, for example, may not be acceptable within the culture because of stereotype perceptions about gay men being less masculine. And this has strong implications on individual self-acceptance and willingness to disclose their orientation and/or gender identity and seek necessary medical treatment. Traditional perception of the patient-doctor relationship is another barrier. So Latinx patients often perceive that the patient-doctor relationship is paternalistic. So they may be concerned that asking questions and seeking advice related to LGBT health may affect their relationship with their healthcare providers adversely. And lastly, there's the fact that there's diversity among the Latinx LGBT population. Although many Latinos or Latinx individuals, share core cultural values, physicians aren't often aware of the significant diversity and heterogeneity among this population in terms of their countries of origin, religious beliefs, educational attainment, and acculturation. In the same way, providers also can often fail to understand differences among various LGBT subpopulations, as their healthcare experiences and needs can also be different. So all this is why representation matters in healthcare. Having providers who identify as LGBT and/or Latinx can make a significant difference for patients who lie at the intersection when seeking medical care. And on that note, we have invited today Dr. Patrick Cahill from Hartford Healthcare and Christian Mendez-Baez from Edge, New Jersey to share their perspectives from the field. And I'll give a brief bios on both. So Patrick is a primary care provider and infectious disease expert with significant experience in matters of LGBT health. He's the medical director of HIV primary care at Hartford Healthcare and holds other positions within the health system, such as Director of Antimicrobial Stewardship for the East Region and Infection Prevention Chairperson for Wyndham Hospital. He's previously worked for Cape Cod Healthcare and primary care for HIV patients and infectious diseases clinical services, and as a telehealth infectious disease consultant for Sitka Medical Associates. He's also authored publications for organizations like the American College of Physicians, UMass Amherst, and the Society of General Internal Medicine on infectious disease and primary care topics. Patrick earned his MD from the Ross University School of Medicine in Dominica, West Indies, and his BA in chemistry and Spanish from UMass Amherst. Next, we have Christian. Christian is the Prevention Services Manager of Edge, New Jersey, an organization that started in 1992 with a commitment to respond compassionately and responsibly to the needs of those living with HIV, as well as to LGBT communities by providing supportive services, housing opportunities, prevention strategies, and education. Christian is also part of JBWS, a nonprofit organization that provides safety, support, and solutions for those dealing with intimate partner abuse, creating a community-wide culture that refuses to tolerate the presence of any form of intimate partner violence. Christian earned his Doctor of Medicine and Clinical Psychology degrees from Universidad Iberoamericana in the Dominican Republic. He holds a dual certification in toxicology and Brigham and Women's Hospital, Harvard University School of Medicine, and a master's in psychotherapy interventions from Universidad de Salamanca in Spain. I'll be asking Patrick and Christian some questions to get insights and share their experience, and then I'll open up the forum for questions. So Patrick and Christian, thanks again so much for joining us.
Absolutely. Thanks for having us.
A pleasure. Thank you.
So let me start. I have a different set of questions. Some relate to your career path and career decisions and experiences, and other questions relate more to the topic of LGBT health specifically. So let me just ask the career side first. If you can just share more insight into your current roles and responsibilities at your respective organizations. So Kristen, being a prevention services manager, what does that role look like for you? What are your responsibilities? And similar, Patrick, as medical director for HIV primary care, what does that look like for you? So let's start with Kristen.
Primarily is providing or removing any barriers that a patient might have in order to access prevention, HIV, STI prevention, and also linkage to either care, treatment, along the sides of any social services needed once you're conducting the intake and once you're right in front of the patient and you're having that conversation. As you mentioned before, the Latinx LGBTQIA plus community does have a lot of barriers and suffers a lot when it comes to social, when it comes to medical access. So for me here is just removing any barriers and connecting right away and getting things moving.
Okay, that's great. That's very interesting. I definitely will ask more pointed questions around that. Patrick.
So currently my role is just being established within the system. This is kind of a new position for me, but I'm taking over the medical management of most of the primary care HIV positive patients that come through our clinic. And another part of my role is going to be to expand services. And we're going to be doing that by reaching out through persons who inject drugs. We're also involving the local LGBTQI community to try to expand testing programs and linkage to care as well. And we interact with all of the surrounding community healthcare providers and local organizations in an effort to try to engage persons that are not currently involved in care and try to bring them in where we have a pretty comprehensive set of services.
That's great. And in terms of your motivations to pursue a career in medicine, specifically in areas of HIV care and prevention, what motivated you to pursue this career path?
Myself, so I knew I was going to be an infectious disease doctor from pretty early in medical school. I just really enjoyed the particulars of that subspecialty, the microbiology, and basically being able to be engaged with patient care all of the time. And specifically in regards to exposure to underserved communities, I rotated a lot through medical school in the suburbs of Washington, D.C., where there is a significant amount of poverty, and they're primarily African-American population, but a significant amount of Latinx individuals as well. And really just kind of fell in love with the whole career path and have been fortunate to continue that.
Yeah, what about you, Kristen?
I grew up in a medical family, and when you're a kid, they're primarily taking you everywhere from the hospital to just the office. So you sort of like learn that. And then you go through any social services. In order for you to graduate high school in the DR, you have to serve X amount of hours. So obviously there was the hospital. Then moving forward, once I enter med school, I work with the Dermatological Institute and the World Health Organization in the outreach and care and treatment for those who suffer leprosy. So it's just kind of like, okay, then I move over here, and I don't know, everything kind of fit all together. I do definitely love being around here, especially because of who I am, especially because here I get the chance to be who I am without hiding or anything, and serving the community that I love, that I embrace in so many ways.
That's great. And yeah, I was gonna ask more about like your experience, you know, being identifying as LGBTQIA yourself. How has that been, you know, both I guess in your current role at Edge, which sounds like it's great, or in other prior roles that you've had in the field? Have you had any? Has it been positive overall? Have you seen representation of other LGBT healthcare professionals that you've worked with? What's your take on that?
It's been, I have to say, amazing.
Yeah.
Living, because you know, you work in healthcare primarily, you're there from 8 until dawn and beyond, and having a family that you kind of identified, it's just phenomenal. Everybody is, you know, working together. There's no issues around. And again, it's just like belonging to the house of where you're working. Right now, I'm working in the House of Edge, and the House of Edge primarily gives you a space to be who you are. It's all about fun, but primarily it's focused on the patient, on that good experience, on removing again barriers that someone might have, and providing that service to it. You know, avoiding that, making the patient feel, I guess, uncomfortable in many ways. Totally cultural humility trainings. We do provide that, and our staff is just, you know, as one of us, as the patients comes in, immediately is received with a welcoming smile, and respecting, you know, the pronouns as well as their preferred name. So that kind of like opens the door to an exclusive and an experience that people will never forget, because again, you're recognizing them for who they are, you're respecting them, you're giving them that space and that treatment that maybe for the first time they'll ever have.
Yeah, no, that's great to hear. And Patrick, has it been a similar, would you say, similar experience for you as well?
Probably not. You know, confession time, I'm not a member of the Latinx community, and you might have been able to tell by my name. And actually also not a member of the personally LGBTQI community, but I've over the years been a very passionate advocate of linkage to care and promoting closing those disparities or gaps within the healthcare system, because everywhere you look, it's easy to find good healthcare if you have money and you have a good job and insurance. But you gave such an excellent summary leading off about some of the statistics that represent barriers to linkage of care for these communities, and you know, I just don't, I can't help myself from trying to help the most underserved people that exist out there. And as you mentioned, I mean, this is a huge hole in medical care, and it doesn't just affect the individuals involved, but really the community as a whole.
Yeah, no, no, that's a good point. And I actually, just on this particular point, I talked through sort of a very, I would say, like high level, or as much of a high level summary as I could. I didn't present all the statistics that are out there, but I gave a few. But from your experience, from both of your experiences, what would you say are the most common areas where healthcare providers tend to fall short when serving LGBT populations, and if possible, more specifically, LGBT and Latinx populations? If you want,
yeah, there are enormous barriers, as you mentioned, and I've heard this from feedback from both patients, coworkers over the years, that when they tell healthcare providers about themselves and tell them about their sexual orientation, and even, you meet people that are contemplating gender reassignment, etc. There is not widespread acceptance within the healthcare community, which seems shocking to me, but it's true, and that's something that needs to be done away with, basically by education and reaching out and trying to engage more providers and persons in the community with this.
What about you, Christian?
I think cultural humility is one of the things that we need to tackle in terms of having more providers involved with LGBTQIA plus healthcare. Again, you have to take it and put it out there. Respect for the pronouns, calling someone by their preferred name, that is definitely a way. Also, I have to say that as someone who have actually been through finding a provider, is never that easy as part of the community to actually feel comfortable. It's like you go to places where let's just say you're looking for I don't know, a primary care physician, and you enter, and again, is that building that relationship with the physician, with the provider, that you feel comfortable enough that you're able to have conversations without feeling that sort of sense that you're judging me, or are you going to say something that I might interpret it as a different way, or how fully and in depth are you into my healthcare? Let's just say, as a gay man, you often go out there, and not doing this as a stereotype, but let's talk about HIV and STI testing. Do you actually want, as a physician, as a primary care provider, how many actually sit down with their patients and are able to have conversations about HIV and STI? And when I say conversations, again, non-judgmental conversations, conversations that are open, that the client or the patient is able to talk about their health, about their sexual behavior. And again, we're talking about prevention, and we're talking about PEP and PrEP. I've encountered a lot of primary care providers who are not really doing that or giving or even opening up to the idea of prescribing MPEP and PrEP because of whatever core values they're holding to, and that for me it's an issue, it's a problem. As a provider, you're there not to judge, you're there just to assist, to guide, and to primarily give this person, this patient of yours, what this patient wants. In that way, as a provider, we need to respect the choices that our patients are making, even though sometimes you don't understand. You try to guide them, but not to push or lecture. And sometimes I tend to feel that within the community.
Right, and that's very interesting. How do you think what do you think would be like a good approach, or as an effective of an approach as possible, to get the buy-in from these providers that are not prescribing medications like PEP or PrEP because of whatever core values that they may have as individuals, but how would you go about trying to change their minds? Maybe have you had that experience before, and have you been successful at it?
It's more about educating them. As medical providers, we need to be humble. We don't know everything, and we are not gods. We need to follow, and if we're really committed to our patients, we need, again, to listen, active listening. If there's something that as a provider I don't know, I can ask my patient and say, hey, what exactly is MPEP? What is PrEP? And then, you do have the representative coming in and out, but it's also part of you to investigate and to go and get that knowledge from where there's a lot out there in the internet. There's a lot of there with your colleagues that they were willing to provide. Again, it's more about active listening. It's more about non-judgmental. And it's more about understanding that we're moving forward. And if we're really interested in ending the epidemic, the HIV epidemic, we need to educate the ones that are coming up And with that, and just the new generations of providers and the new generations of LGBTQIA plus community, especially in the Latinx community.
Right. Patrick, anything you want to add to that?
Yeah, very well put, Christian. And the other thing besides trying to spread some education to other providers around is to often first let them know that I'm there as a resource. And if there are issues like this that come up that they're not comfortable dealing with, then you know, I'm happy to try to take the ball from there, but at the same time try to give them some feedback as to how that, you know, opportunity could have been addressed, really.
No, definitely. And in terms of community engagement, Christian, just going back to like knowing that your role is all about decreasing those or reducing those barriers and promoting awareness and education, what have been some successful community engagement measures or initiatives that you've worked on that you're really proud of? And have there been any that target specifically Latino LGBT patients?
I have to say that the outreach, specifically when it's time for, let's just say, Pride now, everybody jumps into the Pride wagon, okay? So this is an opportunity that we need actually to take and embrace. And it's like, okay, when working in Newark, that was an experience for me because, yeah, you have every single population there from different ages. And just, again, being forward, having those conversations, whether they were one-on-one or just being part of a group or having, let's just say, that little outreach in the testing ban and going with them and explaining to them, you know, that is something that our community needs. It's just, yes, we sometimes get a little too technical, but when you talk to someone at the same level that they are, you know, they're able to understand, they're able to process. So in every outreach, there's always that possibility. There's always that engagement. Now we have social media, and you know, COVID has taught us a lot in terms of how to do the outreach via social media. Everybody has a phone. You know, it's more about you going out there. You know, providing a space. Again, it has to be a safe space. A space that you are able to communicate, frankly, with that community that is definitely needing that help, that needing that guidance. So, you know, you mentioned success. Yes, Newark was a success in many ways. Here, now at Edge in the Morris County area, that primarily goes into Sussex as well. You know, being able to be visible, because that's the other key point. You know, as Latins, you're not seeing a lot of us, I guess, mostly when it comes to prevention, when it comes to HIV. And if you do, most of the times you get to see the negative side of that. But it's time for us to shine. It's time for us to put ourselves out there, you know, to be talking about this, to go to church if you need to go to schools, and, you know, having those conversations with the students, specifically the young ones between the ages of, I would say 13 to 24, because we're actually seeing an increase when it comes to new diagnosis in that age group, followed by the ones of 24 and 35. So yes, and even in the ones of 50 plus.
But when you say diagnoses, is that diagnosis specific to HIV or HIV? Wow.
Yes.
And on the topic of just HIV prevention and care, are there any recent developments that you both have seen that have excited you, that make you feel hopeful? And if you can talk to those, that'd be great. Patrick.
Okay. Yeah, there are a couple interventions that have come out, specifically the longer acting injectable antiretrovirals, which can be used both for PrEP and also therapy. Those are extremely exciting, and a lot of patients have been willing to get on that bandwagon, basically. And along those same lines, over the last, less than a decade, I would say, there's been a significant increase in excellent, well-tolerated combination antiretroviral therapies that are out there that, you know, allow people to simplify their lives a little bit. And And yeah, those are the big things that come to my mind.
Great. Christian, anything you want to add?
I'm gonna piggyback on what Patrick said in terms of the
Yeah.
injectable. The injectable PrEP is something that we're waiting. Supposedly, we're gonna get
Oh.
it in 2 years, along with Descovy for those
Yeah.
assigned female at birth. There's also the studies of combining not only PrEP with an antibiotic to use as prophylaxis for STI. So that's something that also that is exciting. Also, we have to put out there the campaign of U equals U. That has been fantastic. Now you get to see that if you're undetectable, you're untransmittable, and how amazing life is for those who are living with HIV, that no longer is a death sentence. And along the way, you get to see mixed status couples getting together. And so it's always, that is hopeful, when you get to have a patient who is having a baby and, they're in this mixed couple, it just brings you again that hope, because it was something that you would never think about.
Yeah, that's amazing. How, like, just going back to the injection, as I feel like there's a lot of good things happening. Going back to the injection, how is that going to work? Is it an injection that you get? Is it like a vaccine that you get every so often? Is it one and done on a monthly basis? How would that work? Whoever wants to take it.
They're going to be, so the way they have it set up right now, at least for therapy, is lead in with the same 2 oral versions of the medications that will be injected, and selecting patients carefully and ensuring that those patients that are being offered this treatment are going to be followed closely and are ones that return to clinic regularly and are not apt to miss doses. Those injections would be periodic, more like every 8 weeks rather than anything longer than that at this point. But yeah, I mean, I think that for a lot of patients who have been on antiretrovirals for a long time and are very stable and are ready to get a little bit more space from a close follow-up in the clinic, it's a good option. Yeah,
that's amazing. And just on the topic of Descovy, obviously Descovy is an alternative or substitute for Truvada that has emerged in the last few years, I want to say. What do you tell, for anyone who wonders which of the 2 they should take, what would you tell those individuals if there's any marginal or significant difference between the 2? Christian?
There is, like, Descovy is kind of like the 5G right now, if you want to put it in that term. It does have, in many ways, if for example, if you have a patient who is to have some sort of like renal or kidney issues or any, bone density issues, you will tend to go more towards Descovy. But again, it's not that every patient that you see that is on Truvada is going to go into Descovy. So the efficacy is really good for both of those medications.
Right. Anything you wanted to add to that, Patrick?
Or no? No, I think that was well put.
Okay, cool. Then just going back, I think Christian mentioned the pandemic, and that made me think about telehealth. And knowing, Patrick, that you've done some consulting work in the realm of telehealth, I was wondering, what role do you see telehealth having in expanding the reach of care for LGBT individuals or patients?
I think telehealth is going to remain very valuable depending on the type of community that you're involved in. Certainly in the more rural ones, that's going to play a huge role going forward, and it should, where people legitimately have to drive hours to access medical care. But even within the more urban communities as well, it is an excellent option to just offer a way to keep patients linked to care, really. And that's the biggest advantage that I see to it, regardless if we're doing it via Zoom with video, or just even with revolutions in the, I hate to talk about billing, but like we can actually bill for a telephone call now, where we're engaging the patient and we're talking to them about issues that are important with them. And that is going to expand that use within the healthcare community for sure.
That's great. Yeah, I've been in the last few months, I was reading quite a few articles about how the spike, there's been a lot of debate about the spike in telehealth over the last year and whether that's going to be, those levels are going to be sustained now that the pandemic has kind of subsided in the country. But I mean, a lot of them were saying like maybe not at the same rate that they were at the very beginning of COVID, but certainly higher than they were before. Because I think that before the pandemic, back in 2019, the statistics said that roughly 8% of visits in a given year were like telehealth visits, and that spiked to like 70% at the very beginning of the pandemic. And now it's back at like, I think 30%. So that's very interesting. Then in terms of, you know, when you think about patient engagement, what do you think would constitute a successful patient engagement strategy for LGBT individuals of color? Christian?
I would have to say visibility. You need someone there that actually represents you, so that way things can be more invited, so that way you see and you feel comfortable going in. That's primarily the first step. And actually having providers who are able to, again, understand where the patient is coming from, a provider that is no judgmental, and is taking good care of it. You know, as Latinx, I mean, we have our own issues with healthcare.
Yeah.
We tend to postpone things for whatever reasons. And that comes also within our core values. So being able to have a provider that understands a little bit of our backgrounds and the different things that we need to navigate in order to actually get to where he wants us to be. It's more about the patients. It's more about, again, the building that relationship with the understanding.
Patrick, anything further you want to add?
No, I totally agree with what you're saying, Christian. The only thing I guess I would add is just being, offering the patients a chance, similar to what you're saying, but speaking their language and being able to engage with them on an eye-to-eye level, and making sure that you're engaging them to the point where they recognize that you and the patient are creating a plan to improve their healthcare together. It's not, like you mentioned earlier, it's not this paternalistic relationship that has traditionally been the case. It's more about just showing them that they are an important part of their own healthcare.
Right. Yeah. And in terms of advice that you would give, what advice would you give members of the audience who are either current students in healthcare or healthcare professionals interested in LGBT health? I think, Christian, you mentioned earlier humility is a big one. What other piece of advice would you give someone who's in that position?
Just be open. Just open your ears. You got to listen. You also have to have, that compassion within you. Honestly, if you ever thought that you were going to get into medicine because you were going to get a lot of money and have a social status, then this is not the career. Because let me tell you, along the way, yes, you might reach a certain point, but your patience has to come first. And that relationship is going to be the one that is going to put you in places that are more gratifying than just money. And that is, again, that rapport that you build with them, that success that you're able to achieve with them together. And, when you get to see someone smiling, when you get to see someone crossing to the other side, when you actually get to see someone that says, wow, I finally understand what U equals U is. I'm finally adhering to my treatment. Then that's definitely an amazing way, So that's what it is.
Absolutely. Patrick, what are your thoughts?
100% agree. It is all about the patient-centered care, and that's where everything has to start and end. The other thing that I would recommend is that people practice and learn how to take a good sexual history from their patients. And as you mentioned earlier, Christian, just engaging them in the sense of recognizing them as an individual and how do they want to be addressed and how do they want to be called, and that'll help them return and want to continue to engage in care.
Great. And just last question before we open it up to the audience. What are some noteworthy resources? I know there's plenty of information out there. You can Google search and everything, but from your content that you've read and come across, what are some noteworthy resources that you'd recommend individuals looking to educate themselves further in terms of LGBT health? Like whether it's like websites or any particular publications that you recommend that you think are pretty helpful.
Yeah, so as far as specifics, I'm usually offering patients links from things that are patient focused on, up to date, where I can kind of give them what I consider as not necessarily primary level information, but something that's comprehensive and easy to understand. A lot of the medical journals are excellent, but they can be hard to access if you're not, within a healthcare setting.
Sure.
So hopefully Christian has some more specific thoughts.
So I would go first to the different agencies that actually work with the LGBTQIA plus community. They have it all there. So, like around here, you can come to EDGE, you will have anything and everything you need to know about LGBTQIA plus healthcare. Then you have all the different agencies in Newark, in Jersey City, in New York. Like, you want resources, you can check the ConLore, and they do have a great, amazing resources there. I know that Stanford University is offering a free course in terms of teaching LGBTQ health. So you can always go there and it's for free. You can choose whether you want that to be 3 weeks or 6 weeks.
Yeah.
And again, if you really want to know more about, why don't you just have a conversation with one of your friends? Say, hey, look, if I have someone, where should I refer this person who is seeking X, Y, and Z? Because, there's a lot out there, but because you're living that experience, what would be the best place for me to go or to send someone?
That is definitely true. When it comes to referral, you always go with the referral that comes from someone that you trust before going to what you find online or anywhere else. So that's a very good point. So that concludes the moderated panel. Now we're opening up to the audience. So we have one question here. How can we be advocates for LGBTQ, not only for individuals, not only in our organizations, but within our own community where unfortunately homophobia and transphobia are very present? How can we navigate having these conversations with older generation Latinx individuals? Christian, I'll let you take this one.
All right. So first of all, Pride is the 12th month of the year. If you're talking about respect, if you're talking about, equity, equality, if you're talking about healthcare, it shouldn't be only the month of June. It's the whole full year. So how do you have those conversations? Well, you got to speak up. How do you support? How do you become an ally? Unless you're not part of the LGBT, but you have a brother, a sister. They're your blood. They're your family. You have a friend. Right now, everybody has a friend or have a family member. So addressing the elders is primarily removing every single stereotype that they had. When I came out, the first thing that came out of my mom was, oh my God, you have AIDS. And the first thing that came out of my godfather, that was the second person that I kind of went to, is like, does that mean that you're going to dress as a woman? So again, it's now that we have, I just say, all the resources within our hand, it's just having a nice conversation, sitting down, going over all those, myths and beliefs. Obviously, religion is going to play a huge part in that. And yes, you're going to go back and forth. Don't lose your patience. Don't lose your coolness. Just put it out there. And the same way that you're expecting them to understand, please also understand that this might take them a little bit of a time. And if you do it with humbleness, if you're able to communicate and express your way in a way that they're able to understand and feel, remember, emotions, they'll be able to get someplace.
Yeah, no, that's a very good point, and it's funny / sad to hear about what your mother said.
Yes.
Because that was the exact response that I got from my father when I came out there. But I think, yeah, I think it's approaching conversations with, particularly with older people in the Latin community. It's trying to not necessarily, it's like you have to have a balance where you're standing your ground, but you're not also like in their face telling them this is how it should be, because it's also a culture where respect, especially respect to your elders, is very important. And it's about sort of navigating those conversations in a very, try to be thoughtful in your approach, try to be thoughtful in terms of how, pressing the other person to tell you why they believe what they believe. And most of the time, yes, it'll be because of religion, but then coming up with counterpoints in a very sort of thought out way. And it's more of a, emotion plays into it, but not necessarily let yourself get carried away by the emotion, at least from my experience, because you want to make sure that the other person, it doesn't get into a screaming match, right? Which can easily happen in the Latin family. And in terms of like being an advocate, I think whenever you find yourself in a situation where someone says, a slur, or someone is making some sort of stereotypical comment, whether it's in the professional environment or outside of your professional environment, just making sure that you correct that person and tell them that that's not right for X or Y reason. And Patrick, I know that you don't identify LGBT yourself, but I think from your own experience as someone who's an advocate and an ally, what advice would you give to those who want to be fiercer advocates themselves?
Education primarily.
Yeah.
From my own standpoint, I try to get involved in some of the colleague or community resource groups, which exposes me to different viewpoints, and really that's what it's all about. And at the end of the day, you want to, they say, reach one, teach one. And if you can be involved in some level of education or support, and that will make a difference, and that propagates. And the more you spread that, and the more that you spread the acceptance and the love, then that is going to continue to come around.
Yeah, no, that's exactly right. And then another question, do you find that some clinical support staff unintentionally practice microaggressions against LGBT patients? Have you experienced that? Yeah.
Not necessarily micro.
Yeah. How do you respond in that situation as someone who's part of the clinical staff? Like, how do you approach the conversation with that other person who did the microaggression, or perhaps not microaggression?
I've in the past discussed it in private with those individuals and just talked about how their comments or their actions come across from a patient standpoint, because I get a lot of feedback from the patients when that happens, and that's not something that I'm really okay with in my clinic or really elsewhere. So it's again trying to engage those individuals and trying to let them know how that comes off, and how maybe to adjust their attitude or at least behavior to make our environment more accepting.
Yeah. Christian, anything you wanted to add on that?
Again, it's making the staff know that whomever come across that door is human, first of all, that it deserves respect, that it deserves, you might not agree with whatever lifestyle you want to say or whatever, but at the same time, it deserves respect, because you have to put yourself in the other person's situation. You're a professional of healthcare and you're behaving in that way. And again, the same way that you open the door for our patients to come to you, you have to open the door the same way to our staff. Because again, they might not know how to address it. And we are assuming as provider and as a clinic that they come with that education, with that information, and it's constantly, doing an update on that information, on that education, opening up to the staff, just hear them again, let's listen where you're standing when it comes to this, and how can we improve not only your education, but also, and most importantly, the treatment that you're giving to our patient, because they're not only my patients, they're yours. So you're part, a very important part of the success.
Right. No, that makes sense. And the next question, how do you train healthcare providers in culturally competent care, which can cover everything from ages, ethnicities, sexual orientation, and gender identity, communities of color, and every other differentiation?
As you mentioned, Christian, everybody is starting off as a human, and the more we subdivide and subcategorize people, that's taking away from that fundamental. And really, from my experience, it's about leading by example to a certain degree, and trying to engage others around me in those educational or informative activities or groups that is going to allow that level of exposure and comfort that will then follow.
Right. Thank you. And then last question, we kind of touched on this before, but do you have any recommendations for resources for ongoing training and discussions around the topics of cultural competency, equity, and inclusion? Christian?
Oh, yes. If you want, we can just reach out to EDGE. Go to the edgenj.org, and we can provide that cultural humility training. And now that we can have Zoom, it's very useful in that. And again, if you have an agency around you, just go open that door and ask, because they will give that to you for free.
No, it's very helpful. Great. So we're at the top of the hour. So again, thank you so much to both of you, Patrick and Christian, for joining us today. We really enjoyed the discussion, and I hope everyone else who attended did as well. And just before we leave it here, just in terms of getting in touch with us at NALHE Tri-State, here are different accounts, or email address, or LinkedIn and other social profiles. But yeah, thanks so much everyone for joining us. This was great, and I hope you enjoyed it as well.
Thank you.
Thank you for having us.
All right. Thank you. All right. I hope you have a good night and a cold or a cool 4th of July weekend. All right. Take care.
Bye.
Christian and Patrick, if you can just stay on the call for a little bit, we just want to take a last minute picture.
Oh, okay.
Ooh.
Right.
I mean, I have to put in a certain way.
So
Or should I put?
Yeah, this filter is kind of messing with my hair, I'm not gonna lie. But...
You look like that painter. What's the name?
Bob Ross?
Yes.
Yeah.
Melissa, do you mind stop sharing your screen, please? Perfect. Okay. Perfect. So 1, 2, and Melissa, do you want to show your face for the picture? You don't have to. I can just leave the National Association icon. Perfect. 1, 2, 3.
You got it?
Yes, I did. Thank you very much, Christian and
Thanks,
Patrick.
Lena.
Thank you.
Grateful,
Thank you all for having me.
Gabriel, for moderating as well.
No, of course. No, thank you so much for your help, Lena. And again, thanks, Patrick and Christian.
Thanks, Gabriel.
I hope you have a great night.
You too.
Nice meeting you, Patrick.
All right.
Nice to meet you.
Bye.
Bye.
Bye-bye. Take care.